We've embarked on a workforce innovation project which is funded through the Department of Health jointly with Western District Health Service, which is our local health service. This project sprang out of some steps that were taken a few years ago, 2.5 years ago. The decision was made that we needed to be working more closely for our home-based services across the two organisations, and we actually took the step of co-locating our home and community care assessment officers into Western District Health Services facility. So they don't actually sit with the rest of the team at the moment, they sit with Western District Health Service in a physical team sense, and then interact with the home and community care team that work for the Shire back across in a different location. There's only a road between them, but it turned out that that road was more of a barrier for our assessment team getting entree into the clinical space than it was for them having entree back into our own team. So, in terms of this particular project, what we were looking at was expanding on that initial work and taking it a further step. Department of Health have funded the project through till November next year. We're one of 5 HAC projects. There are 118 applications, so we're pretty pleased about that. And we're looking at putting some additional staff into the space to actually trial the model. One of the things with workforce innovation is it can be pretty threatening to staff and clients both. When you start talking about innovation in a workforce model, most people will hear efficiency, and from that they make a step to say that means there's going to be less people doing this, or there's going to be some change to service. We're hoping there will be a change to service, but we're not looking at doing that in terms of changing EFT, as it were. It's more about saying we have a core group of resources that is unlikely to grow. How are we going to meet growing demand? How are we going to make best use of those resources going forward? And the logical thing there is to start looking for some synergies. So reassuring the project team and those in the broader team that this is additional resource to actually test a new model. It's not taking work away or replacing anyone, and that gently approach to actually let people step into that space themselves rather than have change land on their laps. It's about saying, well, we know we have to change, everyone acknowledges that from the broader workforce, but it's what it looks like, so it's that internal. So we sort of have, there's a little bit of dual messaging going on here, I guess, in terms of what we're doing and how we're trying to achieve it. So what we're aiming for staff to look for is improving the care. So we acknowledge that carers are in the business because they care. They want good outcomes for clients. So it's about saying, well, how do we make that better? How do we improve it? And how do we look at our workforce model and test whether it's the most robust thing going forward? So aiming to improve safety, quality, enhance clinician competency, but also make sure that we're making best value use of clinicians, so that we're not, in rural councils you spend a lot of time on the road between clients, often unpaid for, so you get to travel for free and then do your assessment when you get there, and then you get to travel home again for free. Well, guess what, it's not free, we all pay for that. So it's about saying, well, how are we actually optimising those things, making sure we're going the right number of times and getting the right information. And looking at then further integrating those two workforces across the two employers. So that's what we're sort of talking to staff about. We have a little promotional, this project's only just kicked off, so it is quite new and early to the team. So we're doing some promotional work around the traps. So there's a poster that's gone up with 2 members of our home and community care team and 2 members of the allied health team promoting what we're about for the rest of the workforce, and then explaining what we're doing. So what we're looking for is improving client outcomes in their home, building on the relationship that we already have through the co-location of assessment officers, enhancing teamwork, supporting new roles, using technology. So very simple messaging to staff about how we're improving client outcomes and their work experience through the shared workforce model. The dual part of the messaging is this is a funded project, and we need to be able to say to what we're doing for the Department of Health. So in a slightly more technical space, it's around taking those complex clients, which are clients that have multiple services and a level of intensity of support in home to remain in home. How do we take those, integrate assessment integrate our contact points with them, establish the correct path for clinical outcomes, so making sure that while they need clinical support, they're getting it, but it's through a pathway that's logical, clear, efficient, that we're aligning the points of contact. So every time somebody goes into one of those complex care client homes, they should be adding value to a shared care plan outcome across the whole portfolio. So a lot of our staff in the home and community care spend a lot of time in these clients' homes, many more hours than clinicians do. We might be there, in really complex cases, we might be there 2 hours a day. So our opportunity to actually support clinical outcomes and provide feedback to clinicians in an efficient way is not probably being captured. So how do we do that? One aspect of the project that staff are finding a little confronting at the moment, but we're working through it, so we're getting there. We've found a client who's very keen to be involved, is through remote assessments. So how do we send someone in with an iPad, looking at using the allied health assistance in the first instance to actually do a remote assessment. So to take the Skype feed, scan the environment, so okay, here's the kitchen. I think there's some concern around the sink area, and you've got your occupational therapist and your physiotherapist, your speech therapist perhaps in terms of food preparation, at the other end doing the remote assessment. So the value add I see there for us is that if, we've actually just transitioned our home and community care workforce to mobile rostering. So we're using Easy Tracker Mobile. They all have an iPhone now, which their rosters come on. They scan into the client's home and out, all of their payroll and it's all done electronically. The ability for them then to say, and actually I've got a bit of concern that the door handles in this, let me just take some photos and send them through to the OT. The OT can then have a look and say, I need to do an in-home visit. I need to send an allied health assistant out to do an in-home assessment remotely for me. Or actually looks okay, thanks for raising it, keep an eye on it, get back to me if you've got some additional indication that it's of concern. So what the actual team is doing in the first instance is looking to coordinate the assessment process. So let's have a single point of contact, that will be our assessment team, and we will collect as much of the assessment information as we can across the whole portfolio, including clinicians. So the OTs, the physios, the district nursing, everyone's been involved in the development of the common assessment tool. So we go and collect one set of information, and then those clinicians can pick that up. They might need to ask one or two additional questions, but all of the core information is right there. So we probably won't ask about existing medication regimes. District nursing probably have to ask that themselves, but that might be the only thing they have to ask. Everything else should be captured through the central assessment. As I said, using technology to undertake that remote monitoring, being able to have an in-home consultation, the multidisciplinary team meeting is where all of those clinicians come together. We've been attending that as assessment team for a number of months now. So we can participate in that, but we can also at the other end have community support workers being with the client and the family, supporting them through their end of the remote assessment so that community support workers are understanding their role in clinical pathways. And as I said, there's particularly some uniqueness, I guess, around the allied health aspect and making sure that we're respecting the role of clinicians, the qualification and skill that they bring into the space, but then value adding through providing appropriate support and pathways for information. One of the things that took a little bit of getting around was the reporting structure. And again, the team's quite on board with this, but the unique thing, I guess, from an innovation context is that this is the project leader sitting here. So this project officer role is one of our assessment officers. They've been seconded into this role. It's a 0.4 role, so they spend 2 days a week doing it. They actually have task supervision of the project. So they supervise the allied health assistants, not in a line management context. They don't approve leave, they don't get involved in performance review, but in terms of project outcomes, they're in charge. So that was something that took a little bit of negotiating with the workforce around saying, how is this going to work? We have two organisations, we have two employment streams, two sets of line management structures. We don't want to start employing people across organisation. That's just going to get messy really quickly. So let's have the discussion about saying, what's the point of difference between task supervision and line management? Is everyone comfortable? Task supervision, project officer, they're the go-to person. For line management type of discussions, go to whoever you report to. So at the moment that's working quite well. As I said, it's only a few months in, but this project officer is working very closely, particularly with the integrated allied health assistants, and working them through their development plan to get them up to speed across all of the clinical areas so that they actually can start delivering in the space. So that's all working well. In terms of outcomes, as I said, one of the low-hanging fruit for us is travel. Having people in cars driving to clients' homes, one after the other, often to collect the same set of data over and over again. We think we've kept this pretty achievable. So identifying savings of 10% when you've got a 1 hour each way drive around a 1 hour appointment, it could, for some clients, it's going to be more like 100 or 200%. Making sure that clinical hours are spent on clinical outcomes, so adding efficiency in, not actually reducing levels of service, but actually making sure we're using it in the best way. The development of shared care plans and the monitoring around those. So we already do the shared care planning across clinical and HAC, but the monitoring isn't necessarily quite as tight as it needs to be. So part of the project is actually shortening those periods of review up to make sure that when we lengthen them out again, we're confident about how long we can have between reviews. And the goal-directed shared care planning. And as I said, it's a funded project, so there's lots of stuff we've promised to do. But mostly it's about efficiency gains, doing the right thing for the right people with the right staff. Some of the things that are really important for us as an organisation in the space are making sure that we're embedding our assessment into that health space so that we're understanding where the clinical outcomes sit. For our community support workers, it's about sort of a level of professional respect, I guess. It's about saying that they're in home as professionals, delivering professional services to clients. How do we actually value the input that's coming back from that workforce in a realistic way? This line here actually comes from our community support workers. One of them actually said to me at a staff meeting, I want to get a t-shirt that says, I'm not the cleaner, I'm the carer. Well, I actually go one step further and say, you're not the carer, you're a community support worker. You're there to support people to achieve their own goal-focused outcomes. So, and yes, you care, I get that, but you're actually not necessarily a carer. You're a support mechanism to enable people to live autonomously and as they choose in their home, not necessarily to facilitate a caring model. I see carer more in the space of that's your family, your friends, your support network. It's that kind of space. The other thing, of course, is the old active service model. That can be quite challenging for people who've been in this community support worker space for a long time, about facilitating people to improve capability and capacity. So we've actually got the opportunity to really value add to that. So the discussion with community support workers is saying, well, the reason you need to have Mrs. Jones come out and help you with the washing is that she's recovering from a hip operation and her occupational therapist wants her to do some bend and stretch exercise. So we can either try and get her to do this for no particular reason, or we can get her to help you put the clothes up. And then it's task-based, it's purpose-driven, you've got better engagement with your client, you're there to help and support that person to go through those processes, but that's why active service needs to be the underpinning value assessment that we're making in terms of saying why are we doing what we're doing. And then, as I said, it's about that respect for the community support workers as in-home professionals. They're delivering, their ability to deliver timely and relevant feedback to clinicians, and the active participation. So one of the things that we're looking at initiating with our first clients, and we're just at the point of looking at a client cohort at the moment, will be in-home journaling. So that not only provides all of the people who are entering the home in a professional capacity to make a note or raise any concerns, but it also provides the client a pathway to actually make notes and give feedback in a way that's actually captured in writing. And then, of course, there's lots of stuff that we're doing about capturing outcomes, and so there'll be lots of evidence gathering and benchmarking in terms of where are people at now, where are they likely to get to at the end of the project. All of those sorts of things have been thought through at the early stages, but I won't bore you with them. So that's pretty much it where we're at with that project.